Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hello, welcome back to Unraveled and Unscripted. It occurred to me that we just sort of ramble, and it's because we really don't script much of anything.
Maybe we should rename it Unraveled Rambling.
Unraveled Rambling. I am Ilene Ruhoy, and this is
David Kaufman. Hi.
We are co-hosts of this unscripted podcast about unraveling and understanding complex illness and chronic disease. And so we are always coming up with topics that we want to tackle, and sometimes it seems like we're discussing the same topic, but there are things that will happen along the way with our care of patients that will prompt another thought or another idea or another topic to sort of grapple with that falls into maybe an overall topic that we've discussed before. Like today, I told David that I want to once again tackle, the approach to the complex patient, and it was born out of this conference that I just recently spoke at virtually about CSF leaks. Frankly, I was just asked to give a talk on CSF leaks at a CSF leak symposium, the Spinal CSF Leak Symposium. It was in Colorado. And it was with a lot of experts in the CSF leak world, those who actually diagnose and correct CSF leaks, so neurointerventionalists, neurosurgeons, and the like. And so since I am not an interventionalist on any level, so I'm not a surgeon, I'm not a neurointerventionalist, I don't correct them, but I see them and I diagnose them and I manage the symptoms of them. And so they asked me to give a talk on, and they gave me this title, The Approach to the Complex Patient. And I thought, oh, this is what Dave and I always talk about. So that's easy, right?
Yeah.
But then when I went to go and sit down and sort of write out the slides, putting it down on paper or on PowerPoint, it's not, I realized that it's not as easy to just sort of write it out. And then I recognized how hard it, and we've always said it's hard for obviously primary care doctors and other specialists who don't understand the complex illness as we've seen it over the years. And I realized it's probably a lot harder than we even have acknowledged.
Great.
And then it sort of made me think into how best to give this talk, right? How best to lay it out. And so over the course of the preparation, I thought, this is something we need to talk about again.
Yeah, that's good.
And obviously I focused in on the CSF leak component. But again, when we talk about the approach to the complex patient, we don't talk about all the various things that could potentially happen.
Right.
And all the various diagnoses and we talk about the septad, but it goes well beyond the septad,
Yeah, sure,
as you know, right?
Sure.
CSF leak is not part of the septad,
Right.
though you can argue it's part of the connective tissue component, right? The hypermobility. Yeah. But that's sort of where I was. I was like, okay, well, there's this top level.
Trees. And,
exactly. Yeah. It's like a tree. And so I felt like it would be appropriate to sort of take it beyond the septad and break down a little bit more of what each of those diagnoses could potentially mean and what more to look for and what more to consider. And so I actually started with trying to figure out how you even define a complex patient. So, I feel like we just bat this word around a lot. A complex patient, complex illness, chronic illness. So have we ever even actually defined it?
No, we've never defined it, but I have literally as you're talking occurred to me one easy way is in medical school and in our training, we're all taught to begin our notes with chief complaint, okay? Mm-hmm. And in non-complex patient medicine, chief complaint is usually, doc, my throat's killing me. Doc, I have chest pain. Doc, I got shortness of breath. Whereas in the complex patient, they're going to say, if you give them time to and you listen, I'm tired, I have headaches, my joints hurt, I have pain, I have nausea and bloat. So there is no chief complaint, actually, is what it comes down to.
That's right.
And as soon as one recognizes that and accepts it, validates it, the patient moves over into this complex illness schema, and hopefully the physician changes channels from single problem to multi-problem and begins to ask their questions.
And that's hard to do,
It's
right?
very
Because of
hard
the way
to
you're
do.
trained. You're
Right.
sort of trained for it. You're right, that chief complaint,
Right.
chief concern. What brings you here today?
Right, exactly. Exactly.
So it's a hard question for patients to answer when you're a complex patient and
Right.
you have a chronic illness.
Right.
And so I think doctors like us, and there are many others like us. I certainly don't like to pretend like we are at the
There's
top of a
hundreds, yeah.
mountain, and but I think that we've made it easy for patients just to sort of say, I have EDS, right? And many patients will just say that to me, I have EDS, and I sort of know where to go from there. So I think that doctors who treat chronic and complex illness understand what that means, at least in terms of what to first ask the patient, and the patient also knows how to respond. But to define a chronic and complex patient is basically a patient who doesn't fit into a chief concern or a chief complaint, who has many different symptoms that have progressed over a period of time. Some wax and wane, some just progressively get worse. It's almost like MS, right? Relapsing, remitting, primary progressive, secondarily progressive. So similar kinds of categories. And I think that, and then they get to a point where all of those symptoms have now coalesced into something that is basically not compatible with a high quality of life, with a functional life, with a productive life. And most importantly, to the patient, they are not the people that they were before all these symptoms began.
Right. So to continue with this model of the way we were taught, okay, so we're taught chief complaint, why are you here today? History of present illness, past medical history, and then on, okay? Well, I would argue that in the complex patients that we see, we should discard past medical history because the entire illness is the history of the present illness, the HPI. All right? And if you as physician think that way, that then demonstrates the value of starting at pregnancy and delivery and working your way forward, or to the present. And I would also argue that every complex patient that I've seen, with a few exceptions in the long COVID population, have a history that begins in childhood. You just have to ask the questions and listen to their answers. And so, in a sense, we've done a great disservice to this population of patients by being taught that we do chief complaint, history of present illness, past medical history, as if you can separate all that out. That's a fundamental error in these patients.
That's a really good point, actually. I never thought about it. It's sort of not only the way we're taught. You're right. It's like one of these notes. It's,
Right.
Past medical history as if it's something that's in the past and doesn't apply necessarily
Right.
now. Although I think the reason why we're supposed to ask it is because it might have relevance. But I don't think anyone ever gave it relevance, right? I mean, I remember just being in medical school and being told to get the past medical history, but how you actually apply it to the present day was never really
Right.
emphasized or stressed, although I think it was sort of implied that there might be something in there that might be relevant, that you might want to know about, kind of thing. But it never was really a focus.
Right.
And I think with a complex patient, the past medical history should be a major focus, right? It should be really applied to what they're experiencing
and
today.
understanding that past medical history really is a history of the present illness
Right.
in these patients. That's the point I want to emphasize.
Right.
That these patients are presenting, with their problems, but those problems they didn't start last year. So history of present illness might be last month or last 6 months or something like that. And that division is very artificial. And sadly, the electronic medical records have reinforced this to a degree that it's almost impossible to retrain our brains.
That's exactly right.
Because it forces you to do chief complaint, history of present illness, family history, and past medical history, and then everything is repeated over and over and over. Every note you see has the exact same garbage in it.
I know.
Until you finally find the assessment for that day, and it's
garbage in, garbage out, right?
It's
That's
terrible.
the problem with electronic anything, frankly.
Right.
But and even speak about with mast cell activation, the allergy component of
Right.
the intake takes on a much greater role of importance, right? But it was sort of something that we just relegated to, like, oh, they're allergic to penicillin.
Yeah, exactly.
But now allergies mean a lot because our patients are so sensitive to most medications, even to supplements, because of the mast cell activation.
So mast cell's a great example. Let's spend a second on that.
Yeah.
In terms of this point we're both trying to make about the history of the present illness is really the history, okay? So before I started taking care of these kinds of patients, when I was in New York and HIV and everything else, I did it the usual way. I mean, HIV was a different approach in some ways, but I would never start with pregnancy and delivery. I would never start with childhood stuff other than usual childhood illnesses. That's the buzz term, right? In primary care. I've since learned so well, so clearly, and part of this I give full credit to Larry Afrin. If you start in childhood, infancy, and you listen and ask the right questions in a patient who you ultimately have decided has mast cell activation syndrome, they will tell you over and over, well, I had trouble with milk, so I had to have soy formula, and I had rashes once in a while, and I had all these allergies to animals, and I had an allergy to a medication, and I had stomach problems, and a lot of sinus infections, but they were never cultured, and the antibiotics never helped. And it's like a light bulb goes off and say, well, wait a minute, that's mast cell activation before you became complex.
Right. Right. And I wonder if that was recognized back then and
No,
treated.
it's never.
If they wouldn't, right, but if it were, would they have become a complex patient?
Yeah, I don't know.
Like,
and
we're
I'm
not
not
gonna know
blaming
that.
those doctors
No, of
either,
course not.
because
I mean,
kids
they
have
can't.
these things. It's like
They do.
It's like when you're told as a child, oh, those are growing pains. Who's going to think, oh, you actually have hypermobility EDS?
Right. Right. And and people always say that kids are hypermobile anyway,
Right.
so how can you even
And they all
assess for that?
complain.
And they all complain. And then they're under stress at school.
Right.
They're under stress with sports activities. And so a lot of it is anxiety
Right.
and, functional dyspepsia.
So I'm not saying something critical of the doctors that the kids saw when they were kids.
Right.
Because in that context, I can see how that happens. What I'm saying is, for people like us who are seeing these patients, we bring a different viewpoint and a different context, and getting that early history as part of the current illness is dramatically helpful.
Incredibly helpful. And what we now know, of course, are things that, take hypermobility, for example. We know it's a risk factor for things. In fact, it's a risk factor for CSF leaks.
Right.
There was a study that was done that, I think it was like 25% of patients with CSF leaks had hypermobility syndrome. But I don't remember the details in terms of how they even assessed that. I suspect it's probably more. I believe that CSF leaks there's a connective tissue disorder underlying. There's been a lot of studies that have sort of proven that. We need larger studies. They were all very small. Yeah. So the point is that hypermobility is very important, and very important to acknowledge early on, because I do think that if we were more preventative in terms of mast cell management, in terms of hypermobility management with regards to connective tissue, though that's hard to do, in terms of even like immune activation. So the mast cells with their innate, and then of course with the adaptive and any kinds of infectious exposures early on in life. I think the sooner we treat things, the fewer risk factors patients will have as they get older in life, and we'll have less risk factors for some of these diagnoses that really are so debilitating. I mean, this particular conference, they actually had to have, beds where because there were patients at this, it was a patient doctor symposium. And so patients also gave talks at this symposium about their experience with CSF leaks. It was a really amazing, and it was all recorded, so it's available. I don't know where exactly, the University of Colorado, I believe. But it's spinal CSF leak. But anyway, it was a great conference. But they actually had beds where these patients could go and take a break and lie down. Because as you know, when you have a CSF leak, it's really hard to be upright for long periods of time without feeling horrible. So, but the point is that they weren't like that as children, right? But yet, as children, there were signs and symptoms that there were potential risk factors. And so I started to think about a complex patient, more in the sense of like they weren't treated early enough, frankly, and
so
they became a complex
huge
patient.
Problem. Think about it. We're seeing these patients late in the game.
Yeah.
Okay. Even when I see a 25-year-old, it's starting to be late in the game, or potentially. And in fairness to their caregivers, their physicians, or whatever, when they're children, how are they going to think of these things, and perhaps then approach management differently? And the only way I can think of is obviously education.
Right. And
that's part of why we do this, is to see if we can get physicians to watch. But over and over, when I have a patient comes in and gives me a 25-year history, there's a part of my brain that says, I'm limited in what I can do to fix everything because the die is cast, the horse is out of the barn, and your point about in a hypermobile patient, any patient with connective tissue disorder, the more inflammation, the more chronic, the more episodes, the worse that connective tissue gets. And if we could only figure out ways to educate physicians in the medical world to intervene earlier,
right.
I think it would be life-changing for these patients.
But what does that mean to intervene earlier? So let's say that you acknowledge that a 16-year-old has a connective tissue disorder. Like, that's sort of where I get stuck. I don't always know what to do. So, but I think you would agree. Well, the best you can do is sort of think about the other diagnoses that are involved, right? So a lot of mast cell management.
I hate to be a broken record, but that's the value of the septet concept. If you, as a pediatrician taking care of a 9-year-old, recognize that this child, this kid, is having connective tissue issues. They're complaining of growing pains and they keep dislocating.
Osgood Schlatter. I mean, I keep thinking of that diagnosis. Like, what does that mean?
Then let that kick your head off to say, well, maybe I should look to see if there's any mast cell issues and some chronic infection or chronic recurrent infection. Could the kid have POTS? I have met so many patients who say, oh, by the way, I used to faint. That's not normal. You don't faint normally. Okay? And that, again, is a signal, potentially, for, hemodynamic disorder, POTS disorder, related disorder. And we know, not even from you and I, but reported by the NIH, that EDS, hypermobility EDS, is clearly associated with mast cell activation syndrome and POTS, or dysautonomia. So if that's now accepted, why can't that be considered for that poor 9-year-old? And you start looking early in order to, one, make the kid healthier and happier, and also prevent progressive connective tissue.
Right. I mean, as you know, you can't give it, there's no pediatric diagnosis of EDS just yet, and that's a problem. You can recognize hypermobility for sure if they have the symptoms that seem to sort of fit with connective tissue problem.
What do you mean there's no pediatric?
Yeah, you can't, under 18, you can't diagnose hypermobility type EDS.
But they're born with it.
No, well, for the known subtypes of EDS, for the heritable connective tissue disorders, if you find the genetic variant, you can get the diagnosis. But hypermobility type, because we don't have a genetic variant, because it's been molecularly elusive, you cannot.
I mean, this is.
You cannot
I'm gonna go
apply
crazy.
it. Yeah, don't go crazy.
I mean, because this is a perfect example of this guideline EBM, evidence-based medicine bullshit. Okay, I'm sorry, you don't really have connective tissue disorder because you're not 16 yet or 18.
Right.
Think about how insane that is.
I know. Well, think about it. I mean, I think about a lot of things that are insane. I mean, even this concept of, you have atopy, right? Eczema, asthma, allergies. Right? Oh, atopy. Like we just named it. What does that mean? Like now it holds such great meaning to me. And, as a neurologist, like I never even thought about allergic stuff. But
me too.
Now in the work that we do, it's all I think about. And I think about exposures and things that are prompting some sort of inflammatory immune response, and why some are so sensitive and so reactive, and yet some other people are not. So, it just, everything is I feel like everything is so topsy-turvy. And it could sometimes be hard. And then I think about the laboratory workup. I mean, so in this talk, I was talking about, the approach to the complex patient. So what do I do? And then I think about the laboratory workup, and I thought, I've been accused. I think it's a harsh word. I don't know if accused is the right word, but of doing like too many labs. Crazy lab work. I'm sure I know that you
get it all the time.
Yeah, because I heard that about you when I first started working with you. And I was like, when I learned what you did, I'm like, that makes perfect sense to me. But why not? Because there's so much to look at. Complex patient, it's complex. That's the whole point, to get to the bottom of the complexity. And, over the years, I've even added to my labs. I used to start with a lot of labs. Now I have even more labs.
Well, it comes back to training again. And
That's
what
right.
we're taught. We are taught, for those of you that don't know this, as physicians in medical school and in training and in residency, where it's really, really drilled in and you get humiliated if you didn't do it right, we are taught you don't go on fishing expeditions. You don't cast a wide net.
Why
you don't
are you
use a
testing
shotgun.
it? You need to have a reason why you're testing it.
These are the terms of accusation that are used. You order tests A and B, and if they're positive, that leads you to C, and if C is positive, you go to D.
Right.
And that might take you 6 months, but too bad, Buster. That's the way it is.
That's the way it is.
And that's what we are objecting to in effect.
Oh, that is for sure. I mean, so when I used to work in a hospital and I would order a bunch of labs, I would occasionally get a call from the lab. And this is before, by the way, I went into chronic complex. So I was just sort of your neurologist.
Right.
Like a neurologist.
Right.
But I would still sometimes think a little bit outside the box, and I would want to check something, and I would get a call from the lab like, why are you ordering this? And so it was almost like offensive.
Yeah, I know.
It's like, I don't know, because I'm a doctor and I want to,
Right.
but now I'd be thrown out of the hospital.
Well, patients have told me that when they go to the patient service center, the draw stations, the phlebotomist will look whose order it is, and they'll roll their eyes and say, "Oh my God, here we go, 40 tubes of blood. This guy's killing me."
I know, but they're important, right? Because again, it's complex, and you don't want to miss anything because you might find a path to treatment for this patient, and that is what is so key about all the labs that we do.
And I agree with everything you just said, and I would add that since most of the patients come to you and me after 10 to 35 years of illness, I'm not going to make them wait another year to get all the tests.
Right, that's right.
All right, and I think that's a crucial point that I struggle with patients sometimes, and certainly with the system. But the patients have already wasted enough of their life.
That's right.
It's time to just throw those rules out and get to work.
Right, and they'll often say, I've gotten a bunch of labs over the past year, and I always say, I can assure you they're not the labs I'm going to do, because it's the usual labs, right? The CBCs and the CMPs and, thyroid panels and, so, and those are all important to get, of course, because you don't want to miss something amiss there. But, these patients there's so much that underpins everything that goes on in their body. So I do a whole lot of like immunoprofiling of both the innate and the adaptive immune system. Because of everything that I've learned from you, I do a whole lot of infectious kinds of workup, though not nearly as extensive as I probably should, because I just need to learn more. And I don't like to order things that I'm not going to know what to do with, though I will say that having you, as my neighbor makes me feel better about ordering some stuff, because I know I can always ask you. But but I definitely sort of have increased the level of infectious kind of evaluation that I do. And then just in terms of even autoantibodies, I mean, there's a ton of autoantibodies that I look for. And I think it's important because I will find something that will show me something like that's dysfunctional of either the innate immune system, the adaptive immune system, and there are treatment options for it. I've found, mannose binding lectin has become one of my favorite tests, right?
Test.
Yeah. So I find deficiency not infrequently. I haven't done the statistics of it.
That test is a good example of something you just said, which is I order it, you order it, we love it, but I don't know what to do about it.
Right. Well, you just sort of see it as a complement deficiency, right?
Another risk factor.
Another risk factor.
Right.
And it's important to sort of gather this information to patients, because then you sort of get this clear picture about what is going on physiologically. And while you may not have the perfect answer just yet, as you know, we're always learning new things, and you never know when something will come up. Well, you'll read an article and be like, oh, all these patients with the MBL deficiency, this might be the answer for them, and that has happened over the years for sure. And so I think it's important to collect this data on patients, because then you have an understanding about who you're treating, and they understand that you might not have the answer or the treatment, but you've learned a lot about them. And I think that, and again, because they're complex patients, I think that's what our role is. That's what our job is.
And the value in ordering so many tests at once, aside from saving time, is all our patients will say, oh, I've been to all these doctors, they do my labs, they're always normal, okay? The fact is, on the panels that you and I order, and most of our colleagues in Mastermind and stuff, I probably have literally one or two patients in the last 10 years where everything was normal. Everything is never normal in these patients. And you find stuff that what was normal is that they weren't ordered. That's the normalcy. They didn't look. And if you don't look, you can't find. And if you don't think of it, you're not going to look. And a great example, I had another patient this week who's really sick for years and decades, okay? And I prep for these appointments. I go through everything, spend a lot of time going through all the labs stuff. So I'm going through her labs, and I'm starting to get a little anxious because everything is normal. It's like, I can't believe this, and everything. And then I get to the immunologics, and suddenly this patient has no T cells and no very, very deficient T cells, deficient B cells, IgG deficiencies. Nobody's ever looked, and everything else looked fine. So, and the point being, you're not going to know unless you look.
That's right. And it's because there's so much to look for, but
Right.
we're not. So the other thing that I'll say about labs is that, and if you ever look at a test menu for a LabCorp or Quest, there are so many labs that you can order that, we're not even taught about.
Oh, I know. I keep learning about new tests.
I know.
I
It's
learn it from you and from other people.
that's where I learn it from different people, and from even I I read the test menus sometimes because I'm always curious as to what
No, I agree.
LabCorp will offer that I could potentially test on my patient.
Right.
So I'm actually looking for more tests to order because I want to learn more about the patients, because I feel like I always there's always like that question as to why is this happening, and unless I have to always be active in looking for reasons for that answer to why. And I guess it's just my nature is to try to figure out answers. That's what I think every doctor's nature, right? That's what we want to do. We want to figure out answers. But I think the way we're trained and the way we're educated is that only goes so far looking for answers. And then if nothing comes up, then okay, well, then tell the patient to come back, in 6 months.
Unfortunately, it's more than that. It's training and education, but that can be over. It used to be that one could overcome that.
Right.
Okay. The problem is the vast majority of physicians, great physicians, the vast majority are employed by corporate healthcare systems, and they are simply not allowed to order these number of tests.
Right.
They're not allowed to.
And insurance sometimes
they're
won't
not
pay for
allowed
them,
to
by the
think
way.
this way.
Right.
And that's, when you said let's go over complex illness patient again, one of my problems is I don't know how to fix that, because it really means fix the whole system. It's,
right.
How do we get physicians who mean well, are very smart, are very well trained, very highly educated, but work in a system, because that's the new American healthcare system, where they're paid based on productivity, and they need to follow all the guidelines and everything else, and they're literally not allowed to order these tests. I hear from other doctors, well, I ordered this, but they wouldn't let me run it.
I didn't know that.
Yeah, it's.
So even though the doctor is ordering it, they're not. The lab says no.
I guarantee
The hospital
you,
says no.
If an employed internal medicine or family practice doc, say at Virginia Mason or any of these places, ordered 40 tubes of blood the way I do or you do, that would be stopped. I can't believe they'd be allowed to do it.
So why do those tests exist then? Is it just for that unique patient who has?
I think they exist because if you then send the patient to the pulmonologist, they'll order alpha antitrypsin, and if you send them to the ID guy, maybe that person will order a mannose binding. So now you have all these silos with all these labs separated,
Right.
and nobody sits down and looks at everything and says, well, wait a minute, there's some interesting connections here.
Yeah.
That's the problem. That's one of the problems for our
Well, it's a
patients.
huge problem because these tests do exist, and they exist for a reason. And, they've created assays to look for these particular biomarkers, whether they're proteins or hormones or neurotransmitters or enzymes. And I think it's incredibly important that we go looking for these patients. We are doing them a disservice by not looking. You can't just order basic labs and say, everything looks normal, so you must be normal. Clearly they're not normal. I mean, we could see it just from looking at them sitting in front of us, right? And from their history and from what they're telling us their symptoms are. So how do you not order tests that exist? We're not making them up. They exist. They're on a test menu.
Yeah, and some of them are not that esoteric or even that expensive.
Not at all.
One of my favorite examples is immunoglobulins, IGGs. Okay?
Yeah.
So I think most physicians, if there's a question about immunologic health or frequent infections, they'll order an IgG level.
Right.
So that's what that test is for our listeners, is a measurement of the total number of immunoglobulins in that person per milliliter or whatever it is. But what they're not ordering is the IgG subclasses. And so there's 4 subclasses. You can have a normal total IgG, and you can have 2 subclass deficiencies, and you're going to be sick.
Yeah, you're going to be
sick. But that's missed.
Because each subclass has a specific role. I mean, there's some overlap.
Right,
but
we don't always know the role, but it's just
Right.
not normal to have deficiencies.
Right.
And, I hate to say it, but I see it all the time. They ask me to review their labs. There's an IgG that was ordered twice. It's normal. Why are you doing this, doc? It's normal. And of course it comes back, it's not normal if you order the subclasses.
Right.
And that's not rocket science.
No, it's not rocket science. In fact, to order it doesn't require any
No.
any knowledge of anything, really. You
Right.
just have to order it. And then to interpret it and to apply it, sometimes it's a little bit of science, but or a lot of science. But it's important because you're right. You can have a normal IgG level, but if you have subclass 2 deficiency, you're going to be sick. If you have subclass 4 deficiency, you're going to be sick. If you, in fact, there's IgG4 related disease, right? With I've actually seen
if it's high,
right? So if it's elevated, you're going to have some pancreatic issues or some liver issues involved. So the point being is that the subclasses are critical to know what the levels are. It doesn't matter what the total immunoglobulin G level is. And, then there's immunoglobulin M and A and E and D. People don't check D, but there's a hyper IgD and a hyper IgE. And if you dive into immunoglobulin diseases, there are lots of different things that are not that common, but are known and are written about that have to do with different immunoglobulin classes. And so I think that it's important to look at. And it also can, sometimes, obviously the IgGs specifically, but there's a lot of autoimmune diseases that just based on levels of IgGs, you can suspect that there might be an autoimmune process going on. And so it sort of sends you down certain paths. And I think that that's what's key about doing the right labs and the right number of labs. And we shouldn't be constrained in doing the kind of workup that we want to do because, again, these patients are complex.
Right.
And then similar to imaging, by the way, I order a ton of imaging and, no one really pushes back now, but I remember at the beginning, I would often get questions by radiologists, how is this going to change your management? And I'd be like, I don't know until I get the results.
Well, that's, again, it's a system problem. I love the insurance companies will question a test like a imaging or even a lab. And they want to know the diagnosis. And I want to say, well, if I knew the diagnosis, I wouldn't be doing the imaging, I got a question here. I'm a doctor. I think the patient could have a broken bone, so I need to do an x-ray. You're not allowed to use that. And so what happens, I'm sure to many of us, is we end up, semi-fraudulent and write something in just so we can get it done. Or I'll say fractured rib, even though I don't know if it's fractured yet.
Right.
That's insane.
No, it is insane. I think it's the system, though. I don't know if I would call it semi-fraudulent because you have to, if I'm trying to rule out a certain diagnosis, you basically have to put that diagnosis.
Right, but why can't we write rule out?
Right, there is no rule out code.
That is actually the intellectual process.
There should be a rule out code. There is no code. So you end up putting that diagnosis and it goes on the patient's chart. Right. And then once, of course, you've ruled out that diagnosis, you have to remove it from the patient's chart. But so, yeah, I think the system is broken in so many different ways.
So we started out saying, what's the approach to a complex patient, right? And if there are any physicians watching or if physicians start to watch, many physicians may say, well, that's interesting, but I don't have those patients. I don't see complex patients.
But they do. Oh, yeah. Sorry.
Okay. And what I would put out there, and you correct me if my statistics are wrong because you're the EDS expert, hypermobility EDS is an occurrence rate of 1 in 5,000 people. There's over 300 million Americans.
Yeah, okay? Absolutely. So that's been documented in literature. I will tell you that it's probably more. I mean, not probably. It is more. Okay. It just hasn't been.
But let's just use that number.
Yeah, that's
1
fine.
in
It's still
5,000,
a lot. Yeah.
Okay? So just think about the millions and millions of people who have it. Not all of them are sick. But if you just start even at that, if you start at the point of trying to make that diagnosis with a kid, that then opens the door to the question of, well, maybe I should think about mast cell activation. Maybe I should think about POTS. Maybe I should think about motility disorder, which might lead to SIBO and leaky gut. And I think it's somehow we have to figure out ways to get physicians to realize this is not a rare disease. Complex illness is not rare. That's such an important point. It's rarely dealt with. It's rarely diagnosed. And there's a near vacuum of physicians who are able to do it and willing to do it. I mean, we're desperately in need of physicians to do this work. And yet, it's actually a really common problem or becomes a common problem.
Yeah.
That 8-year-old with hypermobility EDS may not be a complex patient yet, but give them 10 years. Give them an episode of mono or a tick attachment or a cat scratch or something like that, and bam, they're falling down the rabbit hole.
Yeah, no, absolutely. I mean, and that I feel very strongly about that. I think that there is definitely an exposure component to all this. I think being born hypermobile is not technically a disease. I think that's why we have, again, dancers and athletes. But I think that the vast majority of these patients probably all of them, though not always we identify, but have had some exposure and usually of an infectious etiology. And I've become so, I don't know what the right word is, but I feel like I've ignored, certainly in my previous life, I've ignored the tremendous role that infection has had on our bodies. And I've embraced it a lot in the past bunch of years, of course, with my patients, because it is so clear that that's sort of when things were, slowly maybe declining, but then all of a sudden they fall off the cliff. Right. And I do think that that's going to be one of our topics in the future, because I really
falling off the cliff.
No, well, falling off the cliff, yeah. How you save yourself from falling off the cliff. No, just infection in general. Right. But I think that that's where the systemic immune response really just does a job on the connective tissue. And we just see this all of the time. And it can be hard to rein in. And I think that's where patients become complex. Yeah. I don't know if they're complex in a different sense, maybe. Maybe we need a different word prior to that second hit, right? So we always talk in medicine the 2-hit hypothesis, right? You're sort of born with the first hit, and then the environment is the second hit. And maybe with the first hit, you're still complex, but okay. And then with the second hit, though, is sort of when all
well, we know that's
breaks.
True. I mean,
right.
In terms of EDS or hypermobility, all those Cirque du Soleil people are not sick. They
well,
have
that's
a
my
great
point.
asset, which is their hypermobility.
Right, but and when I go and watch them,
let them get infected.
That's I know, and I actually wonder in sort of this era of COVID, how they're all doing. Frankly,
no, it's a great question.
And I'm just fascinated by it, because that's when we see all of the pathology, right? So before that exposure, and sometimes it's an environmental exposure. It's not always infection, though. I don't know if that's true, to be honest. I mean, maybe there's mold, but I think there's always an infection. Would you agree with that?
Well, when you say infection, bacterial, viral, fungal?
Well, any infection. Yeah. I'm saying it's never just mold. Would you agree that it's never just mold?
Absolutely agree.
Okay,
agree.
That's what I'm seeing.
And one of the reasons I agree is that mold is everywhere. We live in Seattle. Right. You and I are exposed to mold constantly.
Right.
But since we're not ill with other things that are impairing our immune system, our liver's fine, and we can detox the mold, and so no big deal. And
so one question I've always had about mold, and this is just an aside, but we'll get back to the topic, is, are all mold species toxic? Because I
don't know about all.
Okay. Because I'm assuming that there are some that are not.
Yeah.
I mean, the things
to me, it's evolutionary.
Yeah.
We evolved in the presence of mold everywhere, and so we have a liver that is able to detox mold.
We have detoxifying organs.
We have glutathione, and that takes care of it. But if you also have hypermobility, POTS, mast cell activation, SIBO, your glutathione is exhausted and can't keep up, and now the mold takes over and causes trouble. At least that's how I.
And maybe it's just sort of this added insult, right? But then you have hypermobility, so a connective tissue already have laxity. Right. It's compromised as it is. It's not doing its structural mechanical job. Then you have an infectious exposure, a systemic response, and then it's not initially acknowledged and treated early. Right. And I think maybe if there was early treatment, there would be a difference. But it's usually not treated early. It's usually just sort of brushed off.
Well, I think that's one of the messages we're putting forward, which is if a 10-year-old got acknowledged, diagnosed, or understood early, then there might be more appropriate interventions for their viral infections and bacterial infections and things like that, instead of, you just got another cold, don't worry about it, or that kind of thing. So in terms of what you're just saying, you've heard me use this model of the glass, all right? So the glass is full of water. So I would sort of argue that a hypermobility EDS patient, the glass is already half full. So they're going to overflow a lot faster when they get all these infectious inflammatory insults. Right. But it can also happen to the person who does not have EDS, the glass is empty, it just may take longer to overflow. But it will still overflow. And you and I have many patients with CCI, tethered cord, connective tissue disorders, who did not have hypermobility EDS before they got sick.
That's right. That's right. No, that is very, very true. And so then they get sick, and all this seems to happen. And I regularly see, I've been doing more PET scans, and I regularly see hypoperfusion, hypometabolism. And I think I've already mentioned in a previous podcast that we've been doing transcranial Dopplers at Mount Sinai with the ICT, and we're finding almost everyone has low velocity. And so it makes sense. Like, so there, it's, so the, now I just see patients and I just feel like not only their brain, of course, that's what I focus in on, and their brainstem, but like every organ is at risk or is currently under a state of hypoxia. And that, it produces certain metabolites when there's a hypoxic conditions. And that results in its own sort of, different level of events that sort of leads to further demise of organ function. And so I feel like the mitochondria are just crying out for help and for for assistance.
No, I agree.
Because it's just like the state of duress that the bodies are in, and I think that that's what's behind this complex patient.
Yeah, I think, this is a whole nother topic, which you are quite expert at, which is that our patients, at some point, the final common pathway is mitochondrial pathology, and that's where we're stuck. That's why I have patients who I just can't make progress with. It's because I can't rewire the mitochondria.
Yeah.
And that's why we look at rapamycin, oxaloacetate, allopurinol, all these other interventions, when none of which are FDA approved. There's no indication. It's all off label. It's all you and I kind of thinking of things along with hundreds of other doctors.
Right.
But at the end of the day, that's a key piece, especially late in the game.
It
Early in the game,
piece.
I don't think it's the key issue. Late in the game, after 10 years or 20 years of illness, it's all about the mitochondria.
I agree. And so I think, and we've talked about, some medication options, but there's a couple of others that have secondary mechanisms of actions that are mitoprotective. And then, in the next 6 months or so, we're going to be doing some trials on some of them with regards to mitochondrial function. I'm not yet ready to talk about them yet, but I'm just trying to give a little bit of hope.
Yeah.
There's hope to be had. I always believe there's hope.
Well, I do too.
Yeah.
I do too.
Because without hope, again, I don't believe you need hope in life. And I think that there is hope. And I think that we're learning, again, thanks to COVID, of course, which is sort of a shame that it took long COVID, but we've learned quite a bit. And I think we've learned a lot that applies to long COVID. Not all of it applies necessarily to other post-infectious or infection-associated illnesses. I don't know what to call it anymore. But it's clear to me that there's a connective tissue involvement, there's connective tissue compromise. These patients will develop CCI if they're not treated preventatively, they're not treated early, if the pathophysiology of the immune assault is not identified and corrected, and there are various ways of doing so. Certainly, when there's been history of thrombosis or bleeding, that has to be looked at. There's been evidence of vasculopathies with long COVID specifically. I haven't seen it as much in my ME/CFS patients, but again, I somewhat think it might be a timeline kind of thing because my ME/CFS patients have been sick for decades. So I just think that we're learning so much that complexity of patients takes on a whole new meaning now to me, right? So, and that was what my takeaway was when I was preparing this talk about. It was really about for a CSF leak conference, which is like one thing of a debilitating diagnosis without question. And I also thought about how when you think about CSF leaks, and you think about them in almost every complex patient because it could present in a lot of different ways. We always think about the classic, like, the headache. The headache gets worse when you stand up kind of thing. You can't be upright, which, yes, is a very classic symptom, but it can present in so many different ways.
Oh, yeah.
I had a patient who had chronic pain of their side, and, entire GI workups were negative. I did the whole workup for all the compression syndromes of the abdomen and pelvis. I even did a workup for pelvic congestion syndrome. But it ended up being a CSF leak that radiated pain, but the pain that was reported by the patient was more focal, but there was a CSF leak of the same, basically the dermatome. And it was corrected and the pain went away. So that, obviously an unusual case, but it's just, again, complexity of patients they're complex. So you just can't think about it as black and white.
Right.
It's complex.
I think another point to discuss and make is, and again, this is partly for the physician audience, if we have a physician audience.
We do. There are few.
The reason to spend time discussing and thinking about the approach to complex patient illness or chronic complex patients is that's getting worse. Mm-hmm. I would argue that there are more complex, that we are witnessing or living in a rising field of chronic complex illness patients for very good reasons related to everything we just spent the last 40 or whatever minutes talking about. The environment is a chronic source of inflammation. Pollution is a chronic source of inflammation. The crap in our food chain is a chronic source of inflammation. And we've already dealt with the low-hanging fruit in terms of we lower the cholesterol so there's less heart attacks, we lower the blood pressure so there's less strokes, we use our antibiotics freely so there's less acute infections. And so these chronic complex illness population is rising to the top in terms of frequency. And if we don't get the healthcare system to recognize this and physicians to get trained, we are in for such a disaster.
I know.
Okay? And again, COVID is the canary in the coal mine. Look at long COVID. There must be 10 million or more people just in this country with long COVID, and they're just being told, get out of bed and work out.
It's crazy to me. I mean, even just the idea that COVID has been shown to reactivate viruses that are already present in the body. So there's this commingling of viral activation and viral infections and that are going on in any individual patient, and that there is, inflammation and neuroinflammation and microglial activation and, and cognitive impairment. And those who already have cognitive impairment do way worse with COVID. And the lymphatic system is affected, and so therefore the removal of amyloid beta and tau are impaired.
Right.
It's very scary to me. Yeah. It's very scary, and I've said from the beginning. I mean, I was saying this in 2020, but I stopped because I was accused of being like Chicken Little, and the sky is falling. But I fear an epidemic of dementia syndromes or neurodegenerative syndromes, and and I still fear it. And in fact, I fear it even more.
Very reasonable.
I know, and I don't care if I'm Chicken Little.
We are having an epidemic of ME/CFS, which is long COVID. All right.
We already have that.
That's what I'm saying. Yeah. We're in the middle of it, and
right.
I say canary in the coal mine because this is telling us what's going on. At the same time, as we've often said, there is that silver lining of COVID, which is more research dollars. But as has been pointed out painfully brilliantly by Topol in one of his Medscape pieces, $1.15 billion on Recover, gone, and no outcomes, no intervention studies, no treatment studies, no clinically actionable work has been done. They just basically said, we got a lot of people with long COVID for $1 billion.
It's crazy. And there's so many long COVID clinics now. And
I know.
And
And I say that, and I feel badly because I don't want to be critical of some great doctors in the long COVID clinics.
No, there
but
are.
We have gotten so little for that money. And I would urge everybody to read that piece. It's in the August Medscape. Eric, is that his first name? Eric Topol. It is a brilliant piece. Just beautifully written.
Yeah.
And discusses the mitochondrial stuff and rapamycin.
I haven't read it, actually. I'm going to read it. I'm a real big fan of his work, but I haven't read that particular article, so I'm going to read it tonight. But thank you.
But again, I do think there's hope. Sadly, I do think there's hope, and it's sadly because there's going to be so many Americans afflicted with long COVID, and it will destroy the economy if they don't figure out how to deal with it. And that's basically what drives everybody in governance here is the money. So hopefully that will change.
Yeah. Yeah. So, okay. I'm depressed now.
All right, shut up, David.
Right, and that was my entire point when I was preparing this talk, like thinking about complex patients in the era now of this long COVID and what I've seen in the past 6 months in patients and what you've seen and what we've talked about. Yeah. Like I thought complex is just it has a different meaning now. It's not embraced enough. So that's why I wanted to tackle it again. And I think we did a good job at sort of showing, and I think there's even more to say, but we've run out of time. But about like you got to go beneath the surface.
Right,
it's an iceberg, right?
So this is year 4 of COVID, right?
Yes.
Since COVID started, year 4, 4 years.
21,
okay.
20.
I suspect, and I would love somebody to tell me I'm wrong, that there's not a single medical school in the country that is teaching anything about what we've been talking about. 4 years of COVID and long COVID. Is anybody teaching students that? Are they getting more than that 3-sentence ME/CFS piece of information in a textbook? 4 years out.
Yeah.
That's unbelievable.
That is scary.
Yeah.
That is scary. I will say that I'm at least happy that that there are articles about long COVID.
Right.
And when I think about what the tick-borne infection community went through with regards to just doctors, turning a blind eye,
Right,
like it doesn't
exactly,
exist. I'm not
exactly.
going to even talk about it. I'm not going to address it. It sounds like voodoo medicine, all of that. There's a little bit of a different flavor to
Yeah,
the long
there's
COVID.
change. Yeah.
Yeah, so there is some change, but I think we could learn a lot from the Lyme Plus world, and we'll talk about that in another episode. But I think some things are better, but I think a lot of things are worse.
Yeah.
And I'm scared sometimes.
I am too, but I still am hopeful, and I think a lot of change that has to happen, as always, comes from the patient community, patient advocacy.
Yes.
Again, I'll go back to HIV. If ACT UP and all those groups hadn't camped out in Washington and camped out on the steps of the FDA, et cetera, we would still be years behind on creating drugs to treat that disease.
Right.
I really give full credit to them and the scientists that then worked with them and listened and did the research and moved things through faster. And we need to have that ongoing for tick-borne infection, infectious fatiguing illnesses, long COVID, et cetera. And it's happening. I don't mean to say it's not happening.
Yeah, it is happening slowly, but it's happening for sure. Okay. Well, thanks for
thanks for solving the complex illness problem. I don't know if I never know at the end of these things whether we've
accomplished what we wanted to accomplish, or we've confused the issue even more.
Exactly.
Well, I mean, this is our rambling, unscripted podcast, and so this is the insight into our minds, and I'm hoping that it's appreciated by at least some of our subscribers.
Anyhow, thank you for listening.
Thank you.
Write in, ask more questions.
Yes.
We should add, I was going to add at the very beginning when you're introducing that the reason we revisit or will continue to revisit topics we've already done is because in the messages to the Patreon channel from our listeners, subscribers, questions come up that say, oh, I didn't cover that. I should go back and do that. So keep that coming in.
Absolutely. It does help us think about things that we need to clarify maybe or talk about in more depth.
Right.
And so that's why sometimes it sounds like we're visiting a topic, but we hope you're recognizing that we're not saying the exact same thing.
Right.
But thanks for joining us. We'll see you next time. Bye.
Bye.